Alrighty, hi. Welcome to Mad Medicine with Miss P. Sorry, I'm a little off today. I'm still traumatized. I was just in my daughter's room, and I don't understand how one 10-year-old child can be so repulsive. Just the amount of glitter and beads and rubber bands and markers and gobs of paint and candy wrappers. I don't I just I can't relive it. I'm just gonna put it aside, and we're gonna talk about beta blockers today, and probably not every single one of them. Obviously, we're just gonna touch on the ones that I kind of drill into y'all because it's really important you understand how they work. Uh, and I know everybody kind of thinks of beta blockers as they drop your blood pressure or they're to maintain your blood pressure. That's not really exactly how they work. And it's really vital to read the mechanism of action of any medication that you are wanting to learn about or teach about to a patient or understand yourself. Anytime you're looking up a medication, I don't ever bother with classification, side effects, nursing considerations, implications, uses, that sort of thing. All of that is going to be real common sense when you understand the action of the medication. So read the action. Ironically, I don't have a drug book. I have my old Davis drug book from 100 years ago, and it's not nearly as informative as the ones we've been using in the past maybe 10 years or so, 15 years of when I was teaching. Those books, I think, had a really good mechanism of action. And not to say you can't look it up on your phone, but what I find more often on the phone is almost like a Wikipedia kind of expression of their action. It's sort of what you'd like to see or what it was intended, but it's not really what you see consistently. And the reason I can teach this the way I do and so confidently is because I've really paid attention. So any doctor in a doctor's office or even in the hospital, they can kind of order a medication and say, take this, or the nurse will give it to you, or, when the patient goes home, they'll continue to take it. But it's really we nurses that are there consistently seeing the results of these medications. And because I taught for a while, I really kind of experimented. So when we gave these meds, I would have the student go back and recheck these vitals and saw what the difference is or any complaints of the patients. And I saw it so frequently and paid such attention to it that it was easy to really learn what the medications do. Not like what they think they do or what they want them to do or the intended use, but what they actually did. So that's why I teach the way I do. And even still, I see it over and over. So what the patients tell me they take, or what CRNAs or the anesthesiologist or, the MDs, that sort of thing, what they kind of think is happening, because I paid attention for so long, I know exactly what to expect. And not that we necessarily always get what we expect, but I've seen it so frequently that I really have a probably a little bit better understanding than maybe, some nurses or a good portion of nurses, because they're not, I think as nurses, we generally give the meds, treat the patient, tell the doctor, get the results, give the meds, treat the patient. And instead of saying I'm going to give this med, then I'm going to go back and see, did it really do what it was supposed to do? Or what kind of result did we actually get from this patient versus that one and that one? So because over the past 15 years, not only did I have, let's say 10, 12, between, 5, 6 and up to 12 students, and they each had not, one, but sometimes two patients, I was able to kind of experiment on these 24, let's say, given patients at any time, so I could really see what those results were. And that's how I got the information I got. This isn't because I said so. This is our experiments over a long period of time. And even in my job now, I can see what the patients take and then see what their blood pressure is and what they held and when they didn't take their meds and what result we got, or talking to them on the phone and getting their list of meds. I already know their history. And when you really know your meds, and they're coming up with new meds every day. So I'm not going to lie, when I have to look up some medications or the patients, spelling a medication, and as I'm typing it in, there's no such med, so I have to say, are you sure that's not an R instead of a T, or is it TER or TRE? So there's always issues like that to where I'm still learning and still looking up and still realizing that new meds are going to keep you on your toes. But these medications in general, the ones I'm going to talk about, are the ones that I know, like I know, like I know. Now, some anti-diabetic medications, then the combo meds and how they work, and the differences they've used over the years, that's a different story. But right now, what I want to teach in this series for medications is really what I know well, because I've been really paying attention. And I'm going to, dare I say, there's anesthesiologists, cardiologists, other doctors that kind of think they know how it works, but because I'm at the bedside seeing the difference day in and day out, I'm telling you, this is what I saw, and this is how simple it is. So before getting into a longer 5-minute intro, when we talk about beta blockers, when you hear the term beta blockers, what I always tell my students, they'll kind of roll their eyes, and they even wrote it on my car one year of graduation. Thank God I drove my husband's car that day with their little shoe polish writing it all over it, saying, what's a beta and why are we blocking it? When you hear the term beta blocker, what exactly is this beta, and what is it that we're blocking? So when you hear that phrase, know that what we mean is it's a beta adrenergic blocker. And adrenergic is a term given in nerve endings that when stimulated release epinephrine. So you are beta versus alpha, beta epinephrine blocking. So in the long run here, what we're doing is we're trying to kind of calm the sympathetic nervous system. So when it wants to respond, we're kind of like going, shh, take it easy, cowgirl. Everything's okay. Big deep breaths. And that's in turn, when we say beta blocking, that's what we are blocking, is that beta adrenergic, that sympathetic receptor site. So we're trying to kind of calm that down. So when your heart rate or blood pressure wants to increase, the beta blockers are saying, well, we're blocking that, so you're not really able to do that. Or if you have, kind of a sudden increase, these medications kind of, are supposed to cause that effect, that result in relaxing those receptor sites or not allowing them to stimulate those specific reactions. So not all beta blockers are created equal, and that's the other thing. So when you hear calcium channel blockers, they're not all the same. ACE inhibitors, they all work a little bit differently. But if you understand the mechanism of action, the bodily functions that they're trying to specifically inhibit, then you'll understand a little bit more. So you do kind of have to know some anatomy and physiology and pathophysiology of how the body works in response to these things. So like, let's say metoprolol, right? Or as everybody on earth says, metropolol. This patient yesterday, she said it once, she said it 100 times. And I just wanted to tell her, honey, sound it out. Sound out the word. There's no R next to the T. There's no R next to the T. There's no metropolol. No. It's metoprolol or metoprolol. Those are the only choices you get. You can put a different emphasis on a different syllable. That's all you get. You can't turn letters around, at any rate. Metoprolol. When you read about it, yes, it's a beta blocker, but when you really get to the action of it, and given in IV doses, at higher doses and different times, and people are susceptible to different things, and they're more responsive to certain medications, I get all that. But on average, when you read how metoprolol works, it's kind of masquerading as an ACE inhibitor. When it says that it decreases renin plasma levels, you have to understand that renin being released from the kidney causes angiotensin 1 to convert to 2, and 2 creates constriction, vasoconstriction. So if you're decreasing renin plasma levels by using metoprolol as kind of that beta adrenergic blocking agent to the renin release, then you're in turn really just kind of decreasing the ability of that blood pressure to go higher by stopping the constriction. Now, if I took metoprolol, would it drop my heart rate and blood pressure? Yes, because it is in fact a beta blocker, so it has those effects, but I don't have heart rate and blood pressure issues. Not that you would expect, because I'm such a spaz, right? But in general, because I don't have those issues, yes, it would drop my heart rate and blood pressure, because when I have those normal reactions that are in line and in tune and are reasonable for my body, that control my heart rate and blood pressure on their own, then it would drop them, because when my heart rate or blood pressure wants to kind of kick in and increase it as needed with those beta blockers on board, your body's like, oh crap, I can't, I don't have that ability, because those medications are telling me not to. For example, the anesthesiologists are having us tell the patients to hold their ACE inhibitors for 2 doses before a general anesthetic. Because if you understand how ACE inhibitors work, you realize that during a general anesthetic, when your body says, oh no, I'm kind of dropping too low and I need to kind of kick in and create some constriction, some vasoconstriction to balance out my blood pressure to make sure I'm perfusing all these vital organs, brain, kidneys, heart, and so on. Well, with ACE inhibitors on board under a general anesthetic, it's like, they're able to do that. If they're not there, then you don't have that significant drop. So we're having them stop that because their blood pressure is going too low during anesthesia. So with those ACE inhibitors not being able to allow the body to constrict when needed, we're finding that we're having to treat hypotension under general anesthetic. So fortunately, we have a brilliant anesthesiologist that goes to all of these, courses and runs around and sees all these new and improved, studies that are showing that this is the situation. So when you understand the mechanism of action of an ACE inhibitor, and we'll get to that later, you'll understand that the body cannot balance out and constrict when needed to perfuse correctly during a general anesthetic because we're already subduing a lot of those central nervous system in systems to get that desired result. So that's kind of, a common sense thing. If you don't really understand how they work, then it's confusing and you just tell them to stop it because the doctor told you to. When you stop and realize how it works, then it makes sense to you, and then you can maybe explain it to the patient also, because when they're like, well, then my blood pressure will be sky high. And we're kind of like, I know, and that's okay, but because once we give you general anesthesia, we can balance that out. We can give you any injection we need to compensate, but it's a whole lot easier to drop your blood pressure a little bit lower and see how your body responds than it is to try to give you some ephedrine, and raise it back up, and then you can rebound afterward. We don't want that. So you have to understand all those medications and how they work. And I know it seems like a lot, but if you just do a little at a time, it will kick in and make more sense, I promise. So yes, metoprolol will kind of regulate your heart rate also because it does have those beta blocker effects. But my point in bringing that specific medication up is because when you see that someone's on metoprolol, I just kind of check blood pressure and I move on. I don't start asking them about their heart. The other beta blockers that I know well and I understand how they work, like atenolol and sotalol, those I'm going to say, okay, who's your cardiologist? What kind of history do you have? What's your, heart rhythm, or what's, what kind of heart condition is happening, or what's your history? Because I already know those medications aren't for blood pressure. Read the mechanism of action about atenolol. Nowhere does it say blood pressure. Maybe in that last line it will say, given an IV high doses, yes, then it will affect your blood pressure because it is in fact a beta blocker. But when you understand that beta blockers in general are about slowing the heart rate down to allow it to completely fill and completely empty to increase cardiac output because you have a heart problem. So metoprolol can be a little misleading, and don't even get me started on propranolol. I literally have to say, why do you take this? It could be for migraine headaches, alopecia, ED, and sometimes you're like, enough said. I had a patient the other day take it for something completely different. It could for portal hypertension, people take it. So it's a myriad. So you really just have to say, why do you take that? And then depending on, their history, then we'll, get in a little bit more detail. If they say, I get migraines, then, I drop it and move on. But that one's a little bit trickier. But if you understand the mechanism of action, it will make more sense of why that particular med can do a couple different things. And of course, one of my other big ones, carvedilol. As soon as you say carvedilol, I already know you have heart failure. You can deny it. You can insist it's for blood pressure and everything else that goes with it. That's not how carvedilol works. Remember, not literary geniuses coming up with the names of these meds, right? Like Lopressor. What do you suppose that does? So carvedilol, Coreg, C-O-R-E-G, cardiac output regulator. And all my students are nodding along with me because I've said it 100 times. It decreases the peripheral vascular resistance. Now, when you read that in your book, assuming you have the Mosby's, and that's what we taught at it for so long, I'm pretty sure it's Mosby's, it can be very misleading. So when you read the mechanism of action, all the students who aren't paying attention will write, oh, it decreases cardiac output and stuff. I'm like, no. Read it again very carefully and realize what a semicolon is. So when it says something like, it's a combination of an alpha and beta adrenergic blocking activity, or it's a selective inhibitor of an alpha and beta adrenergic activity, which would in turn, semicolon, it says, cause these three crappy things that nobody would want. So it says like exercise-induced tachycardia, orthostatic, I think tachycardia, and decreased cardiac output, which means when you have a beta or an adrenergic response, you would get those things. No pill can cause exercise-induced tachycardia. So be careful how you read these and use your head as you're reading. And I know it can be very jumbled. I've read plenty of paragraphs in the past, whether it's about medicine or something completely different, where I have to say like I don't understand one word in that sentence or that paragraph. Like I literally am gonna have to look up each word of that. I don't know what they're saying. And I understand that, but take your time, slow down, and read it to where it makes sense to you. When you see the semicolon and then it gives you 3 examples of crappy things nobody would want, but you get with an adrenergic response like decreased cardiac output because your heart is pumping faster and you can only spit out so much at one time when your heart is pumping so quickly, right? So it's an example of these 3 things that you would get. It's kind of like if you had an adrenergic response, you would get these 3 crappy things, which we don't want: exercise-induced tachycardia, which obviously happens, which will decrease cardiac output, and orthostatic tachycardia, for whatever reason. So these 3 things we don't want. And after that second semicolon, it says that it will decrease peripheral vascular resistance. So if you want to decrease peripheral, that's, the outside there, vascular resistance, well, who does that help? It's not necessarily helping perfusion because it's resistance from something that is pumping towards the resistance. So that's helping your heart. So what you'll find is that will decrease your aortic pressure. So what it really does is it kind of relaxes and decreases the impact of the heart pushing against the aorta. So it is to decrease the workload of the heart. So I already know that's a heart pill. Like, well, I take that for blood pressure. Okay, well, guess what? 90/60, I'll still give carvedilol. I'll still give you 25 milligrams of carvedilol if your blood pressure is 90/60. I'm still going to give it. It's a life-saving drug, and I've been reamed by enough cardiologists that gave us a hard time when the nurse held the carvedilol. And ironically, me, the instructor, is saying, no, we're going to give the carvedilol. I'm going to hold the Cardizem, the Tenolol, the lisinopril, and the Lasix. Those meds I'm going to hold. I'm not going to hold the carvedilol. It's a life-saving drug, decreasing the peripheral vascular resistance, the workload of the heart. So by relaxing the aorta and giving that heart someplace to kind of spit that left ventricular blood into, it's decreasing the workload of the heart. And this is how I know. Years and years of practice, this is how I prove it to the students. I say, go get the patient's blood pressure. We get ready to give morning meds, right? She's a little old lady, 100 years old, whether she's 200 pounds or 110 pounds, her blood pressure is 160/60. Just accept it. That's what it is. That's where they all live. 170/70, 180/80, 150/50. That's just where they live. So we give the morning meds, and depending on that diastole, I may hold some of those other antihypertensives, but I'm not going to hold the carvedilol. And then 2 hours later, maybe sometimes 3 hours, depending on if the student remembered or not, we go back and check it. One number changed. Instead of being 160/60, they are now 142/63. We're like, how did that happen? We gave them their medication, right? And it only changed one number. That's how I figured it out. And I paid attention and often enough over years and years and years. That's how we figured it out. That carvedilol can change just one number. That's why it's a life-saving drug, and it decreases peripheral vascular resistance. Now, you can go ahead and start your own little experiments. Please do, and give me something in the comments. Send me a PM, whatever. I want to know. But I've done it often enough to see that it changes just that one number. So when I say, what pill are you going to give to change just one number, right? When I give you the atherosclerosis, hypertension, the systolic hypertension speech, and they're 180/80, 190/90, 160/60, 170/70, I'm like, that's not high blood pressure, that's hard arteries. That is a huge workload for the heart to push against that aorta that's hard as a rock, right? So those people should be on their carvedilol to protect their heart, decrease the workload, open up that aorta, and let that blood flow gently into it to not have to have that heart push against it. Because when that happens, what do those patients have? And I know all my students think I have like some ESP. And I'm like, let's go look at the chest x-ray or the echo, and let's see where it says cardiomegaly, left ventricular hypertrophy. How do you think that happened? When you're asking that muscle to push against pressure for years and years and years, what happens? It gets bigger. That's what working out does. It makes muscles bigger. So let's not do that. Let's understand how these meds work. And don't be afraid to mention to a doctor, like, how come you didn't try carvedilol since they have atherosclerosis, systolic hypertension and cardiomegaly as on the echo? Like, why aren't you giving this patient carvedilol? I'm just curious. And there may be a reason. There could be a variety of reasons that I haven't learned about that, I'd like to. But what I'm seeing for 26 years of nursing, maybe 20 of those I've been paying attention, and especially even more so lately, carvedilol, Coreg, cardiac output regulator, is for heart failure. In fact, I have my Davis drug guide, and when I opened it up, the first thing it said under that, I looked it up just out of curiosity, is given for congestive heart failure. I'm like, oh my gosh, look at this. This 100-year-old book is literally telling the truth. And over the years, it's kind of lost that. These books now, and even, if you look it up on your phone, it doesn't necessarily say the truth of it. But because I've been paying attention, I know when a patient tells me, well, I take carvedilol for my blood pressure, I'm like, no, you take the other 3 medications for your blood pressure. That carvedilol is a vain attempt to protect your heart and decrease the workload of your heart by relaxing that aorta. But let's not get into it. Depending on how intelligent they are, I'll try to explain it or get on the subject. And if not, I'll just leave it alone and run with what I've got. But I would be so emboldened to argue with a cardiologist. If you know one that wants to argue with me and teach me something different, bring it on. Because I'm telling you, this is what is the truth. This is what I've seen over about, let's say, at least the last 17 years since a good anesthesiologist got a hold of me and said, pay attention. And I started looking at things differently. How real and how true this is with these medications. And when you learn about them and how they work, like isorsabide. When a patient tells me they're on isorsabide, Imdor, I already know they have coronary artery disease. That's the only thing that medication does. And they don't even say like, well, I'll take that for blood pressure and stuff, because I would have to argue. I would have to set them straight. But that's what that medication does. And that's the only thing it does. And when you learn about it, you read the mechanism of actions, and yes, there's going to be giant words in there that say like, causes negative chronotropic effects or negative ionotropic effects, or what's the other one? Chronotropic, ionotropic, and dromotropic. And you're like, oh, what's that $5 word mean? Go look it up, and you're like, oh, you mean it decreases the force of contraction? Because the heart is so jacked up, it's trying to not make it work harder. Because if you ask it to really flex and pump like that and contract like that, you are risking injury. So when you see things like that, force of contraction, rate of contraction, you have to know that the heart is already in trouble. So read the mechanism of action of atenolol and sotalol and esmolol and Bystolic, like when I see these medications and I already know what's going on with them, that's why I try to get their list of medications first. Now we've kind of changed it up in PAT, pre-admission testing now. So we're doing things in the computer, but even the computer, ironically, has you get the list of medications first. So I'm not even going to ask them about acid reflux if they're on Protonix. That's one less question I have to ask them. But when I get this list of cardiac meds, now I have to say, who's your cardiologist? And I have to, call and get some information and fax over a request, because I already know they have cardiac issues. And then it works both ways. Then, they're not on any cardiac meds, but they want to tell me they have a cardiologist and they had palpitation, so they see them regularly. I'm like, lady, there's nothing wrong with you. Everybody has palpitation from time to time. That's not a thing. Or they had one bout of SVT when they're on phentermine or something. I'm like, I know you want to have all these diseases to make yourself, so much more important than others, but you don't have any cardiac problems. You're not on one cardiac med. You have no cardiac problems, but they want these issues. And then it's vice versa. The patients that are on all of the CHF cocktail, carvedilol, 80 of Lasix, and deny kidney failure. They're on metoprolol, lisinopril, which, despite being on rip-roaring, kidney disease, they're still on a friggin' ACE inhibitor, which is, decreasing the function of their kidneys to begin with. But you'll see like this cocktail, and then they'll like deny it. They're like, oh no, the cardiologist says my heart's fine. Then why do you have a cardiologist? Because I think with all these meds, you have more of an issue than you expect. And sometimes I can explain it, and sometimes I give up. But when it comes to the students, I'm going to explain it and hope you understand as well as I do, and start testing yourself. And if you learn anything else, I still have some students come back and they'll PM me on Messenger on Facebook, and they'll say like, oh my gosh, guess what happened? Or I had an argument with my my supervisor because she insisted this med, and I'm like, nope, Miss Padalano said. I'm like, don't throw my name out there. But when you really learn your meds and you understand how they work, and then you kind of experiment and you see over and over, this patient and this med and this patient this med, and this is what happened when we gave it, and then this was the result here, and you see it so consistently, you're like, well, then it's the truth. I'm not going to not believe my lying eyes because some doctor said so. Or some cardiologist wants to say, oh, no, that's not what happened. I'm like, okay, well, then can you deny the last 400 patients that I can prove had these issues? And that's how I get this information. It's not like because I said so, because I thought so, or I read a book, or I've been in school forever, but not on the floor. I'm on the floor seeing these things. And I can guarantee if any of the nurses out there that have been on the floor, at this local hospital where I work, the same faces I see over and over and over, if they've taken a minute to pay attention, they would agree. And I'm sure there's, an unfortunate percent that maybe aren't paying attention, but I challenge you to do so. I request that you start paying attention, see which meds they hold and see which ones they don't. And early on in my teaching career, one of the biggest things that kind of made me red flag and start, paying attention was, I'll never forget, at the end of the hall on the west, this patient is going downhill fast. They were symptomatic. It was our patient. They were the student's patient. They were symptomatic hypotensive. We started an IV with a fluid. We held all of their medications, and the cardiologist said, give the Carvedilol. I'm like, what? And that's like one of the things that started me really paying attention. And then I looked into it, and I'm like, he said, it's a life-saving drug. You never hold it. Okay, good to know. Now, granted, this is just one little cardiologist in one little tiny town, one tiny little hospital, fine. But then I started really paying attention. And I'm like, you're right. It decreases peripheral vascular resistance. It's a life-saving drug. It's going to decrease the workload of the heart. And the heart's already, failing a bit here, trying to perfuse the rest of the body because the vasodilation is so significant that now the heart's going to try to, pump out faster. So, yes, this makes perfect sense. And I understand it and I get it now. And it's that simple. I know it seems like a lot, and I know I talk fast and maybe use, big scary words, but just take the time. And you don't have to research it, where you're not going to the library with Encyclopedia Britannica and, like I did in nursing school. You just take a couple minutes and pay attention to these big words and see what they mean. And when you realize that they're not that scary and they're pretty simple and they're just not used often enough to where it really sinks in and makes sense to you, then you'll start to really understand and put two and two together. And that's really what I did. I just had a couple, anesthesiologists say, hey, dummy, you sound like an idiot. Come here, let me talk to you a minute, or let me explain this to you. And they really made a big difference. And I started to really understand. And when you do, it's almost like when you, when you learn another language, and then you speak that language, and it makes sense to you. Like I remember, as the only examples I ever have is because I got a buttload of horses, is that when I learned to speak horse, it literally was like, oh my gosh, I'm fluent in horse now. And you can't believe how that horse will respond when you speak their language. When you understand that they learn from the release of pressure, and pressure can just be like a little leaning in or moving your hand forward, and then they immediately respond to it. And they're so freaking responsive. Oh my gosh, so much better than children. So much better than children. I can teach a horse to deal cards, and I can't get my kids to flush the toilet. Like, you can't believe how easy it is. And once you learn like this medication language, you're like, I can look up any med now. So this patient is spelling this medication to me, and I'm like, okay, you are clearly making something up. It's like EZTIMBINE, and I'm like, okay, that's not a real med. Oh, it popped up. I'm like, it's a real med. And then I had to learn about it. And then it happened again. Another one, it started like ETRZM, and I'm like, what? That she can't be right. It's another med. So all I did was look up mechanism of action. I don't care about what it's used for, or its indications, or the side effects. All of that is common sense when you learn how it works in the body. So when you see a medication that says it's going to inhibit the beta adrenergic activity, causing a drop in heart rate, you already know your nursing considerations are to check the heart rate before. And if it's 60 and it's their first dose, I'm not giving it because it's going to get it lower than 60, right? And some of these meds, it says hold for heart rate less than 50, because if we know how beta blockers work, they stop things from getting worse. So if they take it every day, you're not going to see a plummet in it. You're going to see it hold steady, because that's what they do. Now, we'll get into more detail. I have been warned about my videos being longer than 20 minutes, and now we're at the 30-minute mark. So we'll get into more detail on these medications, because as we talk about others, these are going to kick in. Those are just kind of the most important ones I wanted to touch on, and we'll get deeper into it. And you know what? I'm just going to leave my my pet peeve for metoprolol, and we'll just end it with that. I don't even have to come up with a new pet peeve, because that, God, that's worse than prostrate and rotary cup. It literally says METO, meadow. I mean, like it's right there. There's no R next to the T. And I know hundreds of nurses that say metoprolol. Just take a minute and sound it out. It just takes a second. I'm gonna leave it there. And you know, like always, face your fears, forget your failures, follow your faith. Miss you guys. I'm gonna cry.